Hypertrophic pyloric stenosis is more common than any of the gastrointestinal atresias, and it's a very different kind of obstruction in a lot of ways. First, while the atresias tend to happen early in utero, causing symptoms soon after the first feeding, hypertrophic pyloric stenosis involves a slow, excessive growth of the pyloric sphincter, the gateway sphincter into the duodenum. Because the obstruction develops over a period of time, pyloric stenosis only starts to cause problems between 2 to 6 weeks of age, about a month on average, unlike the atresias that generally present soon after the first feeding. The presentation for this disorder has two key buzzwords that you need to remember. First, there may be an olive-shaped mass palpable in the kid's epigastrium. Second, while all of the atresias lead to vomiting when the kid tries to feed, you'll often hear the term projectile vomiting used to describe the kids with pyloric stenosis. This, by the way, is one of the many reasons I didn't go into peds. Anyway, if you had to guess, would you describe the vomit as bilious or non-bilious? Non-bilious, right? If the bile is secreted right here, and the obstruction is right here, then it's not going to be able to leave the esophagus as vomit, projectile or otherwise. So, how can you predict if your kid's going to be the next star of The Exorcist? Well, nobody really knows what makes the pylorus grow that fast, but there are a few associations that you should be made aware of. Firstborn children and males are more likely to get hypertrophic pyloric stenosis, as well as infants that were given macrolides soon after they were born. So, no macrolides for kids if you can help it. Finally, just like the atresias, the treatment for this condition is surgical, and the operation is specifically called a pyloromyotomy because it's an incision in the pylorus.